All right, good morning, everyone, and welcome to the PT Matters session. I'm Derek Rutherford, the Director in the School of Physiotherapy, and it is my pleasure to welcome Amy Prescott to our session for today. I'll just give a little bio about Amy. I know she's going to take us through a great presentation on Beyond the Binary, 2S LGBTQIA Care in Physiotherapy. But Amy is a resident physiotherapist and a recent graduate from the School of Physiotherapy. As a member of the Queer Physiotherapy Collective, Amy advocates for the expansion of gender-affirming services in healthcare. Her advocacy is informed by her experience at the Halifax Sexual Health Centre, where she works part-time, as well as her involvement in the broader community efforts. Currently, Amy is completing a residency in the Brickyard Health and Synergy Physiotherapy in Pilates, where she provides orthopedic, pelvic health, and gender-affirming care. Before I begin, I want to recognize that Dalhousie operates on the unceded territories of the Mi'kmaq, Wolastoqey, and Passamaquoddy peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the peace and friendship treaties. Section 35 of the Constitution Act, 1982, recognizes and affirms Aboriginal and treaty rights in Canada. We recognize the African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched this part of Mi'kmaq known as Nova Scotia for over 400 years. So, without further ado, take it away, Amy.
Hi, thanks everybody for having me. I'm really excited to be here, and thank you, Derek, for the introduction. Again, my name is Amy. My pronouns are she and ze. Just to go over, again, a quick land acknowledgement, just wanted to mention that we're situated in Jipuktuk, the unceded territory of the Mi'kmaq, Wolastoqey, and Passamaquoddy people. As a white settler, I grew up in Onishbekiway, otherwise known as Elliott Lake, Ontario, which in its creation displaced the Serpent River First Nation peoples. And it's also the unceded territory of the Ojibwe and the Anishinaabe people. I am grateful for my Indigenous teachers and my peers who have shared their knowledge, beliefs, and traditions with me over the past few years. The 2S LGBTQ acronym can also not be complete without the mention of two-spirit identity. I have lived experience as a queer individual, and this presentation is reflective of my own positionality within that. And I would like to also acknowledge that not all two people who are two-spirit identify with the 2S LGBTQ acronym. So just quickly about me, again, my name's Amy. I'm genderqueer. I completed a Bachelor's of Science at Acadia University in 2018, and I recently graduated from Dalhousie University with my MSc-PT. I'm currently an orthopedic and pelvic health physiotherapy resident at both Brickyard Health and Synergy Physiotherapy with Pilates, and most recently I'm also working at the Halifax Sexual Health Centre. So I'm in a few different locations. I'm also one of the planning members of the Queer Physiotherapy Collective, and I'd really like to thank a few of my co-presenters, Dr. Cody Primo, Dr. Megan Ray Peters, and Kayla Perez, as a lot of these slides were adapted from previous work that they have already done. I also just wanted to say, too, the queer experience is not necessarily a monolith, so this is very, again, specific to kind of my experience and what I tend to see within my practice. But if anybody else has anything to add, anything that they feel like might be valuable, please feel free. Just a quick roadmap to talk about what we're going to be talking about today. First, I'm going to start by talking about 2S LGBTQ considerations within physiotherapy, then moving on to talking about affirming care and what affirming care is in the first place. Then I'm specifically going to talk about gender affirming care and physiotherapy, and then finally strategies for 2S LGBTQ inclusivity in clinical practice. So first of all, starting with 2S LGBTQ considerations in physiotherapy, you may also notice I'll alternate between using the acronym and switching between queer and trans or non-binary. Just wanted to say that those are similar. I'm using the words interchangeably as such. So within the growing body of literature that we currently have, we see that queer and trans folk are not adequately supported by the current physiotherapy practice, and that physiotherapists in Canada are ill-prepared to support the needs and positive healthcare experiences of queer and trans patients. Specifically, one thing that we're also seeing as well is a greater need for 2S LGBTQ health information within physiotherapy curricula, and that students are receptive to receiving this information and believe they are adequately trained, but may not necessarily be the case within actual physiotherapy practice. Specifically, when we think about the experiences of 2S LGBTQ people within physiotherapy care, Ross and Sechel in 2019 found 4 findings that people tend to experience when accessing care. The first is incorrect assumptions about their sexuality and gender from their therapist, as well as discomfort regarding exposure and physical proximity of bodies. One thing that's important to note is that queer and trans people, we experience our bodies in different ways than maybe our cis and straight peers. And within physiotherapy practice, where there is so much proximity, where there can be so much physical touch, this is one thing that we identify as something that can potentially bring discomfort. Queer and trans people also experience fears of experiencing discrimination when accessing physiotherapy services, and just a general lack of knowledge from their therapist about 2S LGBTQ healthcare needs. I'm not going to spend too much time in this presentation talking about different terminology, but there are 2 that I would just like to mention. First, transgender, and when we talk about the term transgender, we're using this as an umbrella term to describe anyone whose gender does not align with their gender assigned at birth. And around 1% of Canadians over the age of 15 may fall under this definition. I'd also like to acknowledge that there's many different terms used around the world to encapsulate transgender. Secondly, Two-Spirit, which is an Indigenous identity, and is an umbrella term created in the English language to reflect the many complex Indigenous understandings of gender and sexuality and the long history of sexual and gender diversity in Indigenous cultures. It's not the same as being Indigenous and being queer and trans, or trans. And I would like to acknowledge that colonization has involved targeted attempts at Two-Spirit erasure. I would like to also bring this up here, which was shared with the Queer Physio Collective by Denise Taylor of the CPA's Global Health Division Indigenous Subcommittee. This is the story of sacred gender, which was created by Margaret August of the Shishelt Nation. And the sacred gender depicts the face of a person who embodies energy of both masculine and feminine gender identities in a harmonious and perfect balance. At first glance, sacred gender may appear to be symmetrical. However, if you look at it a little bit more closely, the symbols on and around each side of the face are slightly different and complement each other. And this asymmetrical balance represents the sacred beauty of Two-Spirit gender identity and the expression and harmony they bring to our world. I've included a link to Margaret August's website at the bottom of the page as well. When we're talking about intersectionality, this was coined by Kimberly Williams Crenshaw in 1918, and intersectionality is that inequities are not the result of a single factor, but rather the intersections of different social locations, power relations, and experiences forming interdependent forms of privilege and oppression. And it's the combination of our identities and how they are perceived in society that shape our experiences through life and including within healthcare. If you've never had the opportunity to try out this intersectionality wheel and see where your positionality is within it, I really recommend doing this as a practice. It's not something we're going to be doing today in this presentation, but it's really helpful just to kind of identify your social location and where you might be in society in terms of power and privilege. With that power, privilege, or just like social location and social status, you're going to have experiences of bias that come from that, just implicit to your understanding of the world around you. And that's not necessarily a bad thing. Power and privilege can be beneficial, especially when we use that to kind of create the world that we are hoping to see. It's just sometimes being able to acknowledge that bias and understand that your opinion or your point of view is going to be different from the people around you, and that you bring something unique to the table. I also wanted to talk about the concept of allostatic overload, which is the maladaptive changes to homeostasis in the body experienced with repeat exposures to chronically stressful stimuli over time. And what this graph is showing is that when we have a period of stress, typically we have a change to homeostasis and then a period in which that we would typically expect to see homeostatic recovery and return to a baseline. However, with periods of repeat exposure to chronic stress without time to allow homeostasis to return to that baseline, you get this overall maladaptive change to homeostasis. And with this overall maladaptive change to homeostasis, we can see these physiological changes to the body that happen with prolonged exposure to stress. This change can slow tissue healing, impair injury recovery just through chronic inflammation, and increase the perception of pain. And for people who are of a marginalized or racialized community, they're more likely to experience these periods of chronic, stressful allostatic overload. When we think about allostatic load and 2S LGBTQ healthcare and physiotherapy, we can kind of break it down into 3 different sections. The first is structural, and some examples of allostatic load within the structural framework is a lack of privacy in clinics. We think of a lot of physiotherapy clinics. You can think of those curtains that separate just a few different treatment tables or treatment rooms, and that can sometimes prevent people from sharing information that they might be relevant to their healthcare needs, but they just don't feel comfortable doing so. Also, a limited inclusive paperwork intake forms and pamphlets, oftentimes, especially when we're talking about things like menstruation, different things that physiotherapists might look at in intake. It can be very gendered language, and not necessarily knowing or being aware of this can make people feel very uncomfortable, even when they're just like walking in your clinic space for the first time. We also just see a general lack of inclusive programs and services within physiotherapy care. In the interpersonal examples of allostatic load, we have healthcare provider competency, with 1 in 3 trans or non-binary individuals reporting a lack of knowledge from their healthcare provider about trans and non-binary health needs. We also see a shortage of specialized providers or just people who are able to provide competent care in general. And also we have just the experience of homophobia and transphobia that may be experienced by individuals when accessing these services. On the personal level, we have mistrust in healthcare providers, with only 47% of 2S LGBTQ people reported being comfortable discussing some of their healthcare concerns with their healthcare providers. Cost is a big barrier that we see also within as a personal cause of allostatic load. Queer and trans individuals were less likely to have that higher bracket of income, and as a result also maybe less likely to have jobs that are able to give benefits to access specifically private physiotherapy care. And this can just be a huge barrier to being able to even see a physiotherapist in the first place. Mental health concerns and gender dissonance may put people in a place where they're just not even able to access that care because they're not able to take care of themselves in that way. And then also we see a lack of social supports that prevent people from being able to access the care that they need. This is a concept that I talk with my patients a lot about in practice, is the concept of central sensitization. And what we define this is as the structural, functional, and chemical pathophysiological changes to the central nervous system that occur after periods of exposure to prolonged stress, such as allostatic overload. The way I kind of break it down to people is I talk about like a pain threshold that they're experiencing. And when that pain threshold happens, that's when we have that sensation of pain. When we've had pain for a prolonged period of time, which can be that definition of somewhere between 3 to 6 months, our body wants to protect us, and our body's really good at doing its job in wanting to protect us. And so to kind of like, those alarm bells go off, our body's like, whoa, we need to stop doing whatever we're doing because we've been in pain for a really long time. And as a result, that threshold, which was a little bit higher, actually gets a little bit lower. And with this change, we have increased pain that we've been experiencing that's ongoing, but also things that previously may not have been painful can now be perceived as painful. This can sometimes help explain certain chronic pain and chronic fatigue conditions. And it's not that these people are doing anything wrong or that they're not accurately reporting what they're feeling. It's just that individuals who experience changes to their central nervous system through central sensitization have a system that is just more sensitive to stimuli. And like I said, it's just the body trying to protect us. It's our body's alarm bells being like, whoa, we need to stop this. Like, we need to figure this out. And this is helpful, but again, it can affect the quality of life and function of individuals. And then I often explain to people that even though we've had this change, the good news is we can change it back to where it was. It's just going to take a little bit of time. When we think about 2S LGBTQ health disparities, the Trans Pulse Canada project is fantastic and did a really deep dive into all the different healthcare disparities that we may see within our current populations. And we specifically found that there's significant healthcare disparities for transgender individuals and for individuals with multi-marginalized identity or who are living in rural areas. Some interesting statistics from this study is that even though 81% of our queer and trans population has a primary healthcare provider, there's still reported 45% have unmet healthcare needs. Additionally, 12% have avoided accessing emergency care services for fear of mistreatment, and 27% rate their physical health as fair or poor, which again, that's 1 in 4, so that's quite significant. I really like this graph from the TransPulse survey. I think it does a really good job at illustrating just how we're not meeting the healthcare needs of queer and trans populations. So when we're comparing the rate of people who have primary healthcare providers, again, 81% for queer and trans populations, and then the 84% is general Canadian population. We have access to healthcare providers typically for most people. However, compared to the overall Canadian population, 45% of queer and trans individuals do have unmet healthcare needs compared to just 4% of the Canadian population. So just to talk a little bit about affirming care and what affirming care is. And really what we're talking about when we're talking about affirming care is patient-centered care. So it's not something that a lot of us are not already doing, but it's care that recognizes and supports identities stated or expressed by the individual we are caring for, and by celebrating identity while validating experiences with oppression. It's really about meeting patients where they're at and providing tailored care solutions. Like I said, we're not asking for something that doesn't already exist, and a lot of us probably incorporate aspects of affirming care within our current practice. It's if you've done any trauma-informed care training or try to use any of those systems, it's really kind of those same frameworks. And people with experiences of privilege often experience accessing affirming care within their healthcare systems. It's just not labeled as affirming care. So some examples of this would just be cosmetic surgery, but also breast reconstruction post-mastectomy. These are different things that help people feel more comfortable in the bodies that they're in. However, it's not labeled as affirming care, but when we think about it for queer and trans populations, this is when we start to use that word affirming care. I'd also like to talk about this concept of safety math, which may or not be kind of more intuitive for some of us. The way you can kind of think of it is if you've ever been like nervous walking down a street alone at night, and you're kind of like assessing the risk of being like, okay, like, am I safe in this environment? Do I need to be worried about this? Do I need to be worried about that? And this is something that a lot of queer and trans individuals go through when we're accessing healthcare services. So it's our patient's ongoing assessment of risk. How much risk am I putting myself in? Am I about to face any instances of discrimination, assumptions, etc.? How likely am I to receive affirming care? Will I feel comfortable in this space? Is this space transphobic? And how badly do I need care right now? And if they determine that the need is not that bad, they may put off accessing care that otherwise would really benefit them. It's also calculated interactions with healthcare providers. How can I keep myself safe? What do I disclose? Do I hide my gender expression? Do I disclose that? Is it relevant? Do they need to know this? And do I have the energy to correct a clinician if I experience discrimination or an incorrect assumption? And finally, it's also this increased awareness and hypervigilance of bodies within healthcare spaces, specifically related to the physical environment, social environment, behavior, language, etc. And this can occur even well before entering the clinic or the care center. So you often will see people researching where the clinic looks like, how do I get in, how do I find it, and then with this, we really need to be considering the websites, word of mouth, reputations. How are we allowing people to feel comfortable in accessing our spaces, and is it clear how to get to us? Is it clear how to access us? Just a few aspects of transition when we're talking about gender-affirming care. When we're talking about these 3 different aspects, specifically social transition is adjusting gender presentation or gender expression, and then starting to notify and informing friends, family, and colleagues of this change. It may or may not include a name change and or a pronoun change. Comparing this to a legal transition, this is changing name and gender sex marker on any legal documentation. And then finally, medical transition would be accessing any medical service related to gender-affirming care. And some examples of this could be hormone therapy or surgical interventions. It's important to note that not all queer and trans people undergo all or full aspects of transition. And additionally, aspects of transitioning may look different for each individual, and they may access it all in different ways and to varying degrees and varying levels. When we're talking about gender-affirming care specifically within physiotherapy, I'm just going to go through a few different ways that we can provide specifically gender-affirming care, a little bit more from a more kind of medical perspective. But first I'd like to talk about chest binding, which is wearing a compressive garment or material designed to flatten the appearance of a rounded chest. You may see people wearing chest binders, again, that like compressive garment, or you may see people using what we call like trans tape or just like tape. If you see somebody using tensor bandages, we typically recommend against that as it can really restrict chest expansion. So these are the more common ones that we do see. However, it can be really anything that flattens that chest. And it can improve feelings of dysphoria, improving confidence and feeling safer in public spaces. It may also improve participation in occupation, social, and recreational activities, and it decreases suicidal ideation and suicide risk. With this, if we see somebody who's experiencing any negative effects from binding, stop binding is inappropriate advice because chest binding is life-saving care. So this is something that we need to help our patients access safely. Some examples of symptoms that may be experienced with chest binding most commonly are overheating, back pain, chest pain, shortness of breath, and the ones we are most likely to see as healthcare providers may be back, chest, and shoulder pain, shortness of breath, shoulder instability, and changes to rib and spine. When we're going through an intake or just treating somebody who uses chest binding services, it's important to ask open-ended questions to screen for common and medically concerning symptoms, some of which might be skin infection, swelling, rib fracture, muscle wasting, respiratory infection, numbness or tingling, lightheadedness, and dizziness. And if our patients do report to have any of these symptoms, we really need to take a harm reduction approach when addressing these. We need to start by working with what they're doing currently that's already working well and modifying from there. I try to prioritize self-management, adaptability, and strategies that address multiple symptoms. And I'd really like to highlight Dr. Megan Ray Peters here, who is Dal alumni from the School of Physiotherapy as well. They are the expert in chest binding resources. They are fantastic. You can find them at Chest Binding Support on Instagram as well as inclusiveclinicconsulting.com. They helped make this Breathe zine, Journeys to Healthy Binding, which you can access online. But I really recommend checking out Megan Ray's resources as they have so much information available specifically to physiotherapy care that it's really, they're the expert, they're the pro. When we talk about packing is adding a prosthetic, sometimes referred to as a packer, or another item. Sometimes this can be a rolled up pair of socks, to create a bulge or to achieve the look and feel of having a penis. This packer here on the bottom left, this is a stand to pee packer, and it allows a person assigned female at birth to pee while standing, which can be really important when accessing public washrooms or just feeling safe within public settings. Specifically, when we think about it's important to physiotherapy practice, consent with palpation is one that comes up frequently for people who do wear a packer, especially if we're feeling like quads, adductor tendons, inner thigh. We may not realize that somebody actually has a packer, so making sure we're draping patient appropriately and allowing patients to adjust as needed so that we don't necessarily accidentally out them as wearing a packer. We're also assessing for risks of infection and rash, skin integrity. Packers are held in place with a few different methods. One might be using a jock strap. Also, there's different types of tape or adhesives that we can use to keep the packer in place. So just identifying if it's relevant to our patient care at that point in time. What are they using to hold that in place? Do we have any risks of skin integrity, any rashes? As also, people might use the underwear that has has a pocket in it that you can put like a bulge or like packer tape, packer rolled up pair of socks in. So just kind of figuring out what systems they have in place. Again, if it's relevant. Checking in with bowel and bladder habits. Again, sometimes people may not be comfortable accessing public washrooms, public spaces. So checking in, seeing if we're having, people are like not going to the bathroom, holding their voiding mechanics, and how that's impacting their overall quality of life and day-to-day. As well as if it's relevant specifically within pelvic floor physiotherapy, assessing strength, tension, and coordination with use of a packer. When we're talking about tucking, tucking is the process of hiding the penis and the testes, often between the buttock and the inguinal canal. What happens is the penis gets tucked down in between the buttock, and then the testes go back up into the inguinal canal, so they move back into the abdomen. And this can be accomplished with a few different methods again. Sometimes it's with taping, in addition to that, compression garment layering, and also the use of gaffs, which is a tight pair of underwear that just kind of holds everything in place. Again, when we're thinking about this within its relation to physiotherapy practice, we're really checking in with patients if we do identify them as, or if they do disclose that they're tucking, and if it's relevant to their care. Talking about pelvic floor function and pain, overall genital urinary function. Activities and sitting can be really painful, especially like with periods of prolonged sitting. It's a lot of pressure in through pelvis region, and with the tucking it can cause a lot of pain for certain individuals, so trying to find modifications to prolonged sitting postures. We also need to be screening for infection. Just with the urethra closer to the anus, they're at a higher risk of having UTI infections, as well as with the testes moving up back into the abdomen. We're screening for testicular torsion and pain, finding ways we can address this if we do find that the patient has testicular torsion and pain. As well as one thing that's not talked about too often but is relevant is fertility issues. Maybe just broaching the subject briefly with patients. With the testes in the abdomen, they're at like a higher body temperature. That's why testes move with changes in temperature. But if they're up in the abdomen, they're just going to be a higher temperature. So making sure patients are aware of this, and if they are accessing fertility services or plan to access fertility services in the future, talking about different ways we can help modify their current day-to-day or plan for that, as well as how often are they going to the washroom, again, voiding mechanics, and are they reducing fluid intake throughout the day to prevent going to the washroom, causing dehydration, overall changes to the body. This is really important, and finding different strategies we can use to help them improve this. When we're talking about top surgery, there's chest masculinization and chest feminization, which is a surgical chest reconstruction that creates either an appearance of a more masculine or feminine chest. The picture I have here is different types of surgical procedures for top surgery for the masculinization, and also just knowing that there's feminization surgery where we're actually adding chest tissue. The one we most commonly see here in Nova Scotia that the surgeons use is the double incision. And as you can see, this is a really big scar. It can really affect people's function post-op. Patients either travel to Montreal at the GRS, or now we have a few surgeons who are providing top surgery care within Nova Scotia. And mostly, again, what we see, the preferred surgical procedure is the double incision. So like I said, it's a big scar. We're really assessing range of motion within physiotherapy of shoulders, T-spine, ribs. I also do a lot assessing breathing in the diaphragm, especially with the sump pump motion of the diaphragm and the pelvic floor. Breathing is the center of everything. We're going to do it for the rest of our lives, so being able to optimize breathing mechanics for patients is very important, especially with the location of the scar and its relation to the rib cage and the diaphragm. Trying to keep that scar mobile, moving around, especially as that scar heals. People tend to have varying healing timelines with their scars as well. And we can still see that scarring down of tissue if we don't have enough mobility in through the scar over time. So making sure we're keeping scar mobile, moving around, as well as optimizing range of motion as best we can. Optimizing just strength and overall function. A lot of people have a really hard time with overhead reach post-op, especially because you're kind of getting that pulling through like all the fascial tissue. So if we're able to optimize that for patients. One thing that's important to note is compared to double mastectomy surgeries for post-op breast cancer, top surgery patients actually retain their lymphatic tissue. It's not removed. So with swelling, we can really address a lot of changes through like a lymphatic drainage standpoint, as well as if you haven't seen them, there's the JP tubes that a lot of the surgeons within the patients in Nova Scotia use. And typically, few weeks or few days post-op, there's actually two drains that sit on either side of the chest. And those tubes remain until we're draining under a certain amount of milliliters. So for some people, I've seen it I've seen as early as 6 days people being able to have the JP tubes removed, but also for some patients it can go on for 4 weeks. And the JP tubes, they're not very comfortable, especially where the tube goes into the chest wall. It can be very painful for certain individuals. And it also can be very dysphoric. It's having, like, you have two tubes attached to your chest. It's not very comfortable for a lot of people. So from like a physiotherapy standpoint, how can we help improve that? Is it getting a little bit more range of motion? Swelling looks different in every body, but I think kind of inviting gentle movement can be helpful to get a little bit more drainage of fluid. And then also back and neck pain, especially later post-op, especially if people have been hiding a lot of chest tissue throughout their lives. Suddenly they've had that chest tissue removed. They might like stand in a different way. They might walk in a different way. And they might be using muscles that they hadn't really been engaging before. So that can really kind of bring up these instances of neck and back pain, shoulder pain as well. We're talking about different types of bottom surgery. On the masculinization side, we have metoidioplasty and phalloplasty. Metoidioplasty is when we use clitoral enlargement, which allows the clitoris to be released from the hood and the suspensory ligament to create a phallus. Where compared to phalloplasty, we're using different types of tissue and skin grafts from elsewhere in the body. Typically, it's the forearm or the thigh, but again, it really varies, to create a phallus in a multi-stage surgery. We're thinking about, again, its relation to physiotherapy practice. It can be so many things. Breathing is obviously going to be very important, especially with like movement of the diaphragm moving up, pelvic floor reflexively moves up, and then movement of the diaphragm down, pelvic floor naturally descends. So we're really considering how we can optimize breathing to optimize that pelvic floor mobility and mechanics. We're also looking at hip mobility prior to surgery, if there's anything we can do pre-op to help improve post-op optimization, myofascial, connective tissue, internal pelvic floor release, pre and post-op. Just going over bowel and bladder education and function to optimize post-op tissue healing is very important. The healing of the skin graft and the tissue site, it's a very sensitive area. It can take a long time to heal, so being able to kind of monitor that, especially again from a pelvic floor physio perspective, is helpful. Obviously, the surgery is very involved. It can be very painful, and it takes a long time for tissue healing. So just going over pelvic floor pain and different strategies we can do for patients, as well as there's a higher risk of complications specifically with the phalloplasty, and having physiotherapy there to be able to kind of monitor changes to the skin integrity, changes to the graft can be very helpful. When we're thinking of vaginoplasty, this is a surgery that is used to create a vulva and vagina. It typically involves the removing of a penis, testicles, and scrotum to create a vaginal canal or opening, and a vulva, the external genitalia, including labia. Compared to vulvoplasty, this creates a feminine-appearing outer genitalia area with a shallow vaginal canal that may or may not be able to be used for penetration. When we're thinking importance to PT practice, we see a lot of patients in pelvic floor physio for post-op dilation. So when they've created, it's called like the neovagina, so this is like tissue that previously may not have been vaginal tissue that is now being used as such. We really work on dilation with the dilators, so improving or increasing that insertable amount slowly over time, just to allow that tissue to accommodate. We're also doing myofascial, connective tissue, and internal pelvic floor release as needed. Lymphatic drainage with both metoidioplasty, phalloplasty, as well as vaginoplasty is important. There's going to be a lot of swelling in this area, especially post-op. So what can we do to optimize this? We're also thinking about just general stretching and mobility, internal release of pelvic floor tension, and mobilization of the clitoral hood with tissue healing. Hormone replacement therapy, or HRT, is the medical administration of estrogen, testosterone, or hormone blockers to help individuals align their physical characteristics with their gender identity. When we think about its importance to physiotherapy practice, it may not be totally obvious why that we might consider this within physiotherapy, but we're also thinking about changes to tissue physiology. I tend to joke with a lot of my friends who have accessed HRT, specifically testosterone. I just say, I'm like, all of a sudden you just turned into like an inverted triangle. I don't know what happened, but you're one way before, and now you're just like, you're all shoulders. Like, that's what happened. So we see just changes to like the way people kind of their body composition, but we also see changes to tissue loading, specifically with estrogen, knowing that estrogen is going to increase tissue elasticity a little bit. So having that consideration when we're administering different types of physiotherapy services. Again, those body composition changes, people may carry themselves in a different way after accessing HRT and how that influences how they move within the world. Changes to sensation can really vary patient to patient, but just something that we're keeping in mind that after starting HRT, they might perceive things a little bit differently, as well as changes to gait, which we don't really have a ton of evidence in the literature, but it's just something that we talk about a lot within the Queer Physiotherapy Collective, something that we wondering again how that's influencing with hip muscles, they cross into the pelvic floor, and how that can kind of connect with pelvic floor pain. One thing I'd like to mention as well is the concept of trans broken arm syndrome, otherwise known as gender-related medical misattribution and invasive questioning. With that lovely acronym, we tend to use trans broken arm syndrome. It's a little bit easier to say. And I talked a lot about it, kind of mentioned it previously. I'll be like, we're considering these things when it's appropriate, because when we're talking about trans broken arm syndrome, this occurs when a health care provider assumes that a person's medical issues are a result of that person being 2S LGBTQ+. This can happen in a few ways. The first way is the medical misattribution, so incorrectly assuming a medical complaint is related to someone's gender identity or their medical transition, such as assuming somebody's use of HRT causes depressive symptoms. And the second one, invasive questioning, which is asking invasive or unnecessary questions about gender identity or a medical transition. So, for example, asking about a lower surgery when assessing for shoulder pathology. Like I said, and we say this in physio all the time too, everything is connected. So if I'm assessing for a shoulder pathology and I think it might be related to a previous surgery the patient has had, I'm explaining this to them. I'm being like, okay, I'm assessing your shoulder range of motion, but I would like to see how your top surgery scar is healing, because this tissue is connected and I'd like to kind of see how everything is moving and if we have a restriction in one area that is then causing a restriction in another area. So again, it's finding that if you think something might be related, making sure we're explaining that to the patients that we're treating. And again, this can often be driven by our own conscious bias. So just to go over briefly some quick strategies for 2S LGBTQ inclusive practice. I'd also like to mention that Megan Ray Peters, Megan Ross, and Jenny Setchell are validating an inclusive assessment questionnaire that's just going through its final stages right now. And it's a tool that you can use as a clinician to either assess yourself in your own physical practice or assess your clinic in its clinic practice. So we'll go over a few different ways of just like different strategies we can do to address this. Within therapist strategies, just in general practice, being comfortable using pronouns that don't match the ones you expect someone to use, and constantly referring to a patient's name and gendered language. Comfortable being upfront about areas of practice or patient experiences that are new to you, and being particularly aware of the inherent power imbalances and potential discomfort and vulnerability that your patients are in. When using incorrect language, and it happens all the time, language is constantly evolving, and we all do it, just making sure that we routinely correct ourselves and move on, especially if we dwell on it and apologize profusely. That puts a lot more onus on our patient to actually comfort us instead of us providing them with care. And using a clear understanding of having a clear understanding of what aspects of gender-affirming care or steps in gender transition would be relevant to your current practice. When we're thinking about therapist strategies for assessment, treatment, and documentation, practice using consent for disrobing and including alternatives. So for example, are you comfortable pulling up the sleeve of your shirt? If you're not, I can try to palpate through the top of your shirt. Again, giving people the choice. Practicing explicit consent for touch, physical assessment, and physical treatment, especially when moving from one body part to the next body part. I tend to check in. It doesn't take long. But if I'm moving from elbow to shoulder, I'm always telling people, I'm assessing your shoulder, or I'm assessing your elbow. I would like to assess your shoulder now. Is this okay? It's very quick little moments, and if the patient is not comfortable, that gives them the opportunity to say, actually, no. Introducing yourself with your names and pronouns to help people feel a little bit more comfortable, and using inclusive language when referring to spouses, partners, parents, etc. Avoiding discussing sensitive topics when patients are in vulnerable or compromised positions. I find this is something that we do in a lot of our pelvic floor training. One thing I'm really aware of is my body position and my relation to the patient. I'm never putting myself in between the patient and the door. Even subconsciously, having an escape route, especially for like patients to be able to like exit if something were to go seriously wrong and they needed to just get out of there quickly. Subconsciously, that can put people at a lot of ease. And if I'm ever needing to ask like a question that may be vulnerable for the patient, checking and seeing like where my body position is in relation to theirs, I'm always on the floor, especially if I have somebody on the table. I'm trying to get lower than them basically at all points in time. And again, it's subconscious, but that really kind of demonstrates just like that power imbalance instead of like looming over and looking over someone. Or I'm always moving my body to be like within that person's eyesight, especially if I'm treating cervical spine and I need to ask them a question. I'm like moving around the table so that they can see me. It's not something again that takes too long, but it's really important just for that overall therapeutic relationship. And then again, routinely referring to patients by their preferred names and pronouns when charting, and always being aware of scarring or other body differences that may be related to specific gender-affirming surgeries. When we think about strategies for clinics within space and messaging, having an assessment, treatment, or exercise space that doesn't have a mirror. And only 24% of physiotherapy therapists ask their patients if they're comfortable using a mirror. This is important. Sometimes mirrors can bring up this like feelings of dysphoria for the patients that we're treating and can really affect their ability to engage within the physiotherapy care. If we have a mirror, if the person's not comfortable using a mirror, just having a quick curtain that we can pull closed if we're going to access a space so that we're able to still use the space as intended, just without use of the mirror. Having assessment and treatment space that is visually and auditorily private, or give options for assessments and discussions involving sensitive topics. Having imagery around our clinic spaces that depict a variety of relationships and gender presentations. Having bathrooms that are single use with gender neutral signage or a clear gender neutral alternative is available and relatively close, and having that information be not necessarily something that people have to ask for. Having a website that includes a statement of support for 2S LGBTQ patients and an indication of the degree of knowledge or work being done towards inclusive practice. A few different strategies for policies and procedures. Within all phone contact, having your front desk staff or whoever is using the phone, using gender-neutral language or preferred gender language if previously specified, using appropriate names and pronouns when communicating with other members of the healthcare team when talking about someone, onboarding processes for new staff that include 2S LGBTQ competency review and training, and then an anonymous process for all patients and staff to provide feedback that is clearly advertised and available within the clinic setting and or available on the website. Patient tracking systems are one thing that's really important, specifically when we're thinking about people whose name may not match the one that's on any legal documentation. So having a system that allows us to kind of even overwrite that name in the first place. So we're not even seeing, because whatever name is on their system may be completely irrelevant. So having a computer that can just put whatever their name is over top of it and we don't even see the other one. And having this being able to be modified at any time is really important. Anyone completing intake form procedures is comfortable using appropriate language when collecting required information to book the initial appointment. And anyone communicating with the patients over the phone has no difficulty when the pitch of a patient's voice is different from what we expect. And all staff are comfortable addressing concerns, confusion, or questions from non-2S LGBTQ patients and visitors regarding extra questions. Just wanted to briefly mention what we're doing at the Sexual Health Center. So very new to the Sexual Health Center. We are providing physiotherapy services, which is really exciting. These services are patients can self-refer, and it's free for patients to access, which is really great to address that cost barrier to accessing physiotherapy care. they just have to have something, they have to have anything that would be like sexual health related. So pelvic pain, incontinence, but within sexual health, for better or worse, gender affirming care kind of falls under that umbrella. So patients can access us for gender affirming care for physiotherapy at the Sexual Health Center. And I'd just like to take a moment to thank my sponsors, Alexa, Victoria, and Genera, who without them, I wouldn't be able to do anything that I do. They're all amazing and they really support me. As well as my previous Queer Physiotherapy Collective members and co-presenters. If you'd ever like to reach out to the Queer Physiotherapy Collective, I've provided our email, as well as a link to our Instagram page, and then finally my email and my Instagram as well. And thank you. So I've saved a bit of time for questions if people have any. And I can also kind of monitor the chat if people have any questions over Zoom chat as well. Yeah, I can turn on my video. Okay, let's see. Ooh. I think this will work. Okay, they can see. Yeah.
When you were talking about cultural sensitization, do you ever see like kind of the reverse, where their perceptions of pain are like they have like the opposite? I don't know.
Yeah, no, I know what you mean.
Yeah.
I actually was just talking about this with one of my patients the other day, and they were like, yeah, like, I have a really high pain tolerance, and they're just like able to really like endure a lot, but at the same time they're really going through this like period of like persistent chronic pain. And I was like, I don't think it's that like you have a higher pain tolerance. I just think it's because you've been in pain for so long, you just like you have to get through your day to day. So even though their like pain kind of is increasing, they're able to kind of endure a lot because they've just like this is their normal. And that's, I don't know if I like, we can like kind of see that like the goal is like moving it the other direction so that things that are like uncomfortable for that individual can become like more comfortable. But yeah, that's what I tend to see more of is people who like actually are in a lot of pain and they just kind of like get through it somehow and to do what they need to do. Yeah.
You talked a little bit about accessibility of care and information, but there have been situations, especially recently, where advertisement of care has led to safety issues itself. Could you talk a little bit about the interaction that can exist between accessibility and well-advertised care versus the risk that can create for patients with that?
Yeah, absolutely. I think one thing that's really important is if you're going to advertise yourself as providing a care service such as gender affirming care, consulting with people who would access gender affirming care, consulting with people who are stakeholders in that care provision to make sure that the care you're providing is actually something that is gender affirming or that is affirming in whatever way that needs to be. Specifically within like pelvic health physiotherapy, there have been instances where it's been like, yeah, this is like gender affirming care, and then when people go to access that service, that hasn't necessarily been the case. So making sure that if we are providing that service, making sure we've consulted with the right people to be like, yeah, this is actually care that's helpful. And with that, knowing that we're not always going to be perfect too. And if there's ways that we need to adjust our service, being able to do so in a way that is informed by the community or by the people that it's trying to provide care and services for. Yeah.
So you talked about scar mobilization in various surgeries, and I know that's something that's within the realm of physiotherapy. But I know as a previous massage therapist, that was something that we would sometimes address. But a big difficulty was finding massage therapists that have some training or are comfortable doing that and have the knowledge to kind of treat this patient population. Unfortunately, the training is not as robust as physiotherapists, so there's sometimes some things that can fall through the cracks. With the physiotherapy network that you belong to, have you also identified, or do you have a short list of people to refer to help amplify that method of care?
Yes, we do. I do have a list. Alexa just created it the other day. We just updated it. But we have a list of care providers within Halifax that specifically related to top surgery can provide different levels of care. We have so many amazing massage therapists in Halifax who are really dedicated to doing that scar mobilization work post-op top surgery, and they're all fantastic. So we have that list, and then we also kind of compiled, includes like osteopaths, physiotherapists. I can't remember exactly. There's a few other different like healthcare providers, which I can share. And that's kind of, we tried to incorporate everybody that we knew of, but we're also happy to add additional care providers to that list as well. And yeah, I do scar tissue mobilization every day, which I think we only talked about it super briefly in physio school like once, but I would say it's half of what I do. Yeah.
Oh, I was just saying, I thought the term safety math, I hadn't heard that before, but I thought it was really interesting.
Yeah.
I'm just wondering kind of where that came from.
Ray Peters, yeah. I think we brought it up when we were presenting at Congress, and I don't know if they might have coined the term themselves, but it might come from somewhere else, but we loved it. We were all like, absolutely, because it's something that you do, right? Like, it's just anywhere you're going in a space, you're like assessing it briefly and being like, okay, how am I adjusting myself? How am I adjusting my body? How am I adjusting my language? How am I code switching to be safe within this physical space? And yeah, it's something that seems very like innate to certain individuals. Oh yeah, I'm going to check. And I can take your question too.
When discussing bottom surgery, you did omit discussing orchiectomies. I'm just wondering if there's any particular issues that this can cause, or if it generally falls into the vaginoplasty.
Yeah, with orchiectomies, I'm not totally specific, just with like the research that I've done, and I've only seen my mentor has seen like one patient who post-op orchiectomy. Specifically, we do tend to do like a lot of like the from a pelvic floor physiotherapy perspective, we're looking at more of like a rectal exam and kind of assessing through muscle that way to see if it's like what kind of release is needed, if there's any tension, and going from there. It can be really individualized patient to patient too. But again, scar tissue work, mobility work through the fascia, assessing hips always. Very similar to the PT considerations post-vaginoplasty as well. But yeah, I think what we tend to see a little bit more is like potentially doing a rectal exam, just so we're getting that like internal palpation of the pelvic floor muscles to see if there's any deficits that we can address, and also just like going over overall function, pelvic floor pain, yeah, lots of things. Then, and then so when I talk in this slide about allostatic load, I cited that 70 or 47% of patients are not comfortable with their healthcare provider. This is specific. They're asking if this is like healthcare provider or physiotherapist. I think this is data that's in prep by Dr. Primo at the University of Western. I believe it is physiotherapists. I'm not positive on that. Just to go back to that statistic, it is the allostatic load slide. This one. Yeah, and I believe it is, so healthcare providers. I think it's healthcare providers as global, but again, I'm not positive. Yeah.
Hi, Amy, thanks for your presentation. I think it was the TransPulse study where you had on your slide, and I'm just wondering if you can comment. So I caught at the very bottom that this is on 2015, 2016 data or something like that. I'm just wondering if you could comment on if you've seen, because this is really interesting. So have you seen progress that we've made in the last 10 years generally in this area, and where do we have to go to make sure that not just as health providers generally, but specifically? I don't know, because this is, I just caught that this is the data is from
Yeah.
years ago.
Yeah, it's from a few years ago. I think it's still pretty relevant too. Like I think if we ran the numbers again, it would be interesting to see like what changes have been made and what's still the same. I think there's definitely people who are doing work like in specific areas, people who kind of really go out of their way to be like, okay, I'm going to provide this care and I'm going to do it. And then just like kind of within like the global healthcare setting, we're not necessarily seeing that same uptake of care that's inclusive and competent to all individuals and all the different patients that we treat and see. Specifically in physiotherapy, sometimes it feels like, sometimes I'll say something and people will be like, wow, I had no idea. And I was like, oh my God, that's from 5 years ago. Like, what do you mean you had no idea? So it's just like, there's a lot of work within physiotherapy, I think that needs to be done to kind of get us up to speed to where the community is at.
Well, I don't know where I'm supposed to stand, but on behalf of the School of Physiotherapy, Amy, I just want to thank you for your talk today, engaging with us through the PT Matters sessions, and such passion. And I wish you all the best in how you're moving these initiatives, important initiatives, forward here in Halifax, but it sounds like nationally and internationally. So that's great. Thanks again.
Thank you.